Everyone, welcome to our discussion of coronary stent overuse, featuring new data from the Lown Hospitals Index for Social Responsibility. My name is Vikas Sani. I'm president of the Lown Institute. Thank you all for joining us today. We created the Lown Hospitals Index 4 years ago, and we wanted to reframe the question of what it means to be a good hospital. Outcomes are clearly very important. But they're not everything. We believe that hospitals should also give back to their communities, pay their workers fairly, and avoid waste and unnecessary care. So we take all these factors into account when we created the Lown Hospitals Index. Earlier this year, we released data on nonprofit hospitals that give back the most and least to their communities in relation to their tax breaks. That's something we call the Fair Share Index. And last month, we highlighted the most racially inclusive hospitals in the US, those that do an excellent job serving people of color in their communities. Altogether, the index includes 54 metrics evaluating hospitals across 3 main categories: value, equity, and outcomes. Hospitals that earned an A across all 3 categories are part of our honor roll, and they were highlighted in our July release of the annual rankings. So you can see those hospitals and thousands more and how they performed at lownhospitalsindex.org. On that website, you can view all the rankings and sort by hospital location, size, and other characteristics, like whether it's urban or rural, whether it's a teaching hospital or not. So today, we're diving into one particular component of the index. That's avoiding overuse. The Lown Index is the first ranking to evaluate hospitals based on how well they avoid unnecessary tests and procedures. To measure that, we include 12 common services that have been identified as low value in the literature, such as spinal fusion for low back pain without radicular components, head imaging for fainting, and colonoscopy for patients who are over the recommended age. We're excited to present new data on coronary stent overuse, which is one of the low-value services that we measure on the index. But before we get into that, let me introduce our panel today. Dr. David Brown is a general cardiologist and clinical professor of medicine at Keck Medicine of USC. He's published more than 300 abstracts, manuscripts, and book chapters, with the primary research focus being cardiovascular disease outcomes. Dr. Brown is also a member of the editorial board of JAMA Internal Medicine. Thanks for joining us, David.
Thank you.
Dr. Thomas Power is Senior Medical Director of Cardiology and Sleep Programs at Carelon Medical Benefits Management, which is a subsidiary of Anthem Insurance Company. Dr. Power is a board-certified cardiologist and a fellow of the American College of Cardiology. He maintains an active clinical practice in addition to his work at Carelon. Tom, thanks for joining us.
Mr. Cuss, happy to be here.
Dr. Betty Ramber is the interim dean, professor, and Routhier chair for the practice at University of Rhode Island. Her work focuses on healthcare payment reform, ethics, and workforce redesign within alternative payment models. She serves on the state's Cost Trends Steering Committee and is a member of Medicare's Payment Advisory Commission, or MedPAC, as many of you will know. Thanks for joining us, Betty.
Thank you.
So just to kick things off, a couple of questions for each of you. Tom, our audience probably doesn't know that you went to medical school in Ireland before coming to the US to practice. So what's the biggest difference you've seen in the culture of medicine in the US and in Ireland?
Yeah, thanks, Vikas. So, of course, the major difference is that Ireland is a socialized system. And as I was thinking about this, I was going to follow that by saying that that means it's a resource-limited system. But of course, the system in the US is also resource-limited. So perhaps a better way of phrasing that would be that there's more awareness of the resource limitation in Ireland, more awareness amongst practitioners, and certainly more accommodation for that in decision making. The physicians in Ireland are not paid on a fee-for-service basis, except for a very small private sector. But in general, physicians are salaried. And so decision-making does not have any financial reward component to it. There's also considerable difference in training of physicians. The training of undergraduates in Ireland is very heavily emphasized upon bedside diagnosis, coming to a diagnosis or coming to a differential diagnosis based on history and physical exam, and then excluding the most likely diagnosis in the most cost-conscious way. And then lastly, there's not as much medical legal concern amongst practitioners in Ireland. We haven't yet got to where things are in the US.
Thanks, Tom. I went to med school in Canada, and I think every little thing you said, I would check off and agree. That's what I experienced as well. Betty, one of your many jobs is advisor for the Reimagining Nurses initiative on value-based care. So tell us a little bit about the project and how's it been going?
Well, thank you. Reimagining nursing is about unleashing the innovation that's trapped in episodic fee-for-service care that focuses on procedures. And value-based initiatives are very well aligned with nurses' orientation on care. Certainly cure is wonderful, but care is always central. And it focuses on where people live really their lives, not just their illness. So it's well aligned with the nursing model, but there's many, many barriers, particularly among small practices wanting to take on financial risk. So the nurse entrepreneurs that we've been working with started their practices because of their frustration with the gaps in care, the overtreatment at the same time. So many critical needs were left unaddressed. And nurses often know what, but the how, particularly putting together the financial pieces, can be more challenging. So we think it's going really well. And in fact, one of the initiatives was part of the template that led to the new guide model that CMMI has suggested, which is around care of those with cognitive disorders, but also attending to the caregivers, which is actually absolutely central.
That sounds amazing. I want to learn more about that. I trust many in the audience will want to as well. So David, I was just thinking of asking you something, which I'm not going to ask, but you've been at this a while, and you and I have seen this for many, many years, the stuff we're going to talk about today. So you're teaching a lot, you're teaching residents. What do you see in the next generation of clinicians that makes you excited, hopeful?
Very little, unfortunately. We seem to be trapped in a 20th century disease model of coronary disease. And by coronary disease, I'm strictly referring, and I think the conference today is strictly referring to stable or chronic coronary disease, not acute heart attacks or threatened acute heart attacks, which I think everybody agrees that stents play an invaluable and important role. But we're talking about chronic obstruction of coronary disease. We're stuck using a 19th and 20th century model of that, where it's likened to a clogged pipe in your bathroom. And the only way to fix your bathroom is to completely unclog your pipe and let the water flow freely again. Unfortunately, human anatomy is much more complicated than that, and the science really doesn't support that model. So I have been trying to broaden the perspective of the trainees that I interact with, and at the same time discuss evidence-based care with them. And, you know, it meets with variable success, because I may make a point one day, and the next day they're working with somebody that says that an asymptomatic patient with a stress test needs to go to the cath lab. So, you know, we do what we can, and hopefully influence a few people, and hopefully that will at some point start to snowball.
Thanks. Well, let's dive into our topic of the day, which is coronary stent overuse. So for those of you who aren't familiar with the Lown Institute, the issue of overuse, and overuse in cardiology in particular, has been embedded in our DNA for a long time. Our founder, Dr. Bernard Lown, was one of the first cardiologists to question the growing trend of surgical interventions in patients with stable heart disease. And this was as one of the co-developers of the defibrillator, so he kind of had earned his chops to say that. The conventional wisdom was that blocked arteries, as you just heard David say, were like a clogged pipe, and that opening up the arteries with bypass surgery or stents would prevent heart attacks. And it makes sense in a sense. I mean, it's plausible in some general sense. But surgeries and even stents expose patients to risk. And they took off as procedures before we actually had good evidence that they worked. Dr. Lown saw the potential for harm and took a different approach with his practice. He treated most patients with medications and dietary changes, and we used surgery really as a last resort. I was lucky to train with him and be part of his clinical practice for years and to learn how to help hundreds of patients manage their heart disease without surgery. In fact, we used to have so many second opinion patients who would go on 5, 10, 15, 20 years after they'd been told they needed surgery. I actually wanted to have a dinner with all of them, providing testimonials. We never got around to that. As early as 1981, we published research showing that a conservative approach worked. Even at that time, this was incredibly controversial, and it took a lot to get the article published. Since then, Dr. Lown's research has really been validated in study after study, as you can see on the screen, showing that stents don't reduce heart attack rates or death compared to medications alone in people with chronic stable coronary disease. So you can read a lot more about that on our website. But the one, most recent of all those trials is the 2022 Revived trial, which even had me, just amazed. Its design gave PCI or stenting every chance to shine. The trial enrolled 700 patients in a group that had blockages, and those blockages did lead to ischemic burden and some degree of dysfunction or weakening of the heart muscle. And that's a group I would have sent to surgery or stenting when I was practicing. But even in this trial, they found no difference in rates of death or hospitalization from heart failure compared to medications. So, David, looking at this research, it seems like this would be case closed. In fact, you wrote a piece with Rita Redberg about Orbita, which was another amazing trial back in 2017, about it being the last nail in the coffin. So why does this keep happening? Is there good evidence contradicting all of these studies? Are there other randomized trials that are contradicting these?
No, there's zero evidence contradicting. What contradicts it is financial conflict of interest and preconceived biases from the era before we had these randomized trials. But there's absolutely no data that contradicts any of the studies that you showed on the screen.
Well, Tom, I don't want to put you on the spot, but you're a cardiologist. You're also involved in care management. On the payer side, there's got to be a lot of interest in this question. What's the countervailing force? We just heard from David, it's not really evidence. Is there evidence that you take into account or have to take into account?
There isn't, I agree completely with David. There isn't any evidence that changes thinking. But I think the reason that we're still seeing inappropriate use of PCI, it's really a multifactorial situation. There's the fee-for-service payment structure. Certainly, we can't ignore that. There's the fact that the clogged pipe hypothesis that David referred to, it's really hard to change both cardiologists and patients' thinking around the clogged pipe hypothesis. It is very biologically plausible and easy to understand for non-clinical folks. And so, for decades, we have practiced according to that clogged pipe hypothesis, and now it's hard to turn the tide. There may be some medical legal concerns, right? Because if a patient who has a stable chronic coronary disease does not undergo PCI and has an adverse outcome, we know that that is not due to failure to open the stable lesion, but it can be difficult to carry that opinion with a lay jury who sort of buys into that clogged pipe hypothesis. But I completely agree. It's not because of opposing evidence.
Thanks, Tom. As somebody once said, the road to hell is paved with biologic plausibility. Betty, you've done a lot of work on low-value care for MedPAC. What are some other types of services that are widely overused in Medicare? What kind of evidence do you use to determine if that's the case?
Well, and first of all, I want to say I'm speaking for myself, not necessarily any of my affiliations, but the cascade towards overtreatment is pervasive. And nurses end up delivering low value care for many of the same reasons physicians do. They've been marinated in it, they've been taught to do it. And so I'm personally very concerned about this study. I'm also very concerned about overtreatment at the end of life. That's one that causes enormous amount of moral distress among nurses and others, causes a great deal of suffering to patients and families. I'm also very concerned about overscreening, the overscreening that turns perfectly healthy people into patients and victims of our healthcare system. So I do think that part of this payment system is a huge driver, a huge driver. So is the momentum of the status quo. And in fact, I know of nurse practitioner colleagues who actually don't have routine screening mammography themselves, but they're in practices that have that as part of their payment metric and the value metric. So we have a lot of challenges in sort of unwinding ourselves from the momentum that we've created with episodic reactionary fee-for-service reimbursement.
Well said, thanks. Brenna, I don't know, have we been able to launch the poll or should we launch it now? Here we are. So this is for everyone in the audience, and actually our panelists can fill it out as well. So let's fill out this poll, and while we do that, are there any questions from the audience that I'm not seeing any in my chat, but let me see if I can find something. All right. Well, we'll collate the poll, and it'll be interesting to see what people have said. I was wrong, David, Tom, and Betty. We can't vote. At least I wasn't allowed to vote. So here are the results. Pretty evenly split, though. I guess the winner by a hair is afraid of bad outcomes. And I guess that is a mixture of just bad clinical outcomes and legal outcomes, I guess. Otherwise, you know, it's all of those. And that's probably a fair generalization. If one had to say, it's probably a mixed set of motives. A couple of questions. Can you discuss the role of pressure from patients for doing this procedure? I guess to any of you, really, if that's something you want to tackle. And associated with that is, how can an individual patient protect himself or herself from this kind of overuse? Any takers?
I mean, in my experience, when a patient is shown a coronary angiogram that shows a very tight narrowing of one of the arteries, I think it's sort of an intuitive desire to make that go away. And we have fairly safe, fairly effective methodologies, meaning stents, to make it go away. Unfortunately, making it go away doesn't change any outcomes. It doesn't reduce the risk of heart attack. It doesn't reduce the risk of death. It's even questionable whether in the patient with symptomatic chest pain from that narrowing, it's even debatable whether it eliminates angina any better than medical therapy. But it's just an intuitive desire by the patient to make it go away. And, a lot of patient-provider interactions sort of lead patients to that desire.
So
Yeah.
I can launch in there too. I do think there's this underlying belief that everything can be fixed and we just have to do it quickly enough and often enough. But even when people are educated on the risks, it's very hard to change behavior. And if I can give one quick example, my husband was in for his routine meeting with the physician, and I went over all the choosing wising guidelines and this and that, the data, and he hears me, ranting about all this all the time. And when he came home from his visit, he had some of the things on the never list. And I said, "Why did you do that?" And he said, "Well, the physician said I should." So he didn't even ask. And this is a well-educated person who has agency in all other forms of life. So I think this enormous responsibility of how do we really help people understand the potential harms in doing too much without terrifying them about avoiding things that really do make a difference. And I think that's the real challenge facing us at this time.
Yes, I was going to comment that your question really uncovers the weakness of shared decision making, right? So the shared decision making is very time consuming, and it's particularly time consuming if the patient has a preconceived notion of what should be done. So now you have to go through the evidence that helps them to understand why it shouldn't be done. And I think that's unlikely to happen if the gut feeling of the physician is that it should be done. I think then the shared decision making becomes very skewed. And I think that happens a lot with coronary angiography and PCI.
And just briefly, it's often easier to do than not to do, right?
Mhm.
You have patients waiting, you're busy. It's just easier to do. The patient is happy, their family's thrilled that everything was done. And so that the real courage it takes to pause and have the watchful waiting is hard.
And to add to that, there is a huge placebo effect. I mean, I can't tell you how many patients I've gone to visit in the recovery room after having received a stent, and I ask them how they feel, and their response is the best I've ever felt in my life. I can breathe better now. I just feel a greater sense of peace within me, and that's all placebo effect. I mean, nothing happens on the way to the cath lab to the recovery room that would even stress the heart for a patient to even know if they got any benefit from the stent. But when they go home and tell their friends and their family that they felt as good as they've ever felt in their life, and it's a snowball effect. And in the sort of lay population, it's thought to be a great thing.
Somebody had written in the chat just a minute ago that patients consider more care to be better care. And I think that's absolutely true. And I think it's most true in older people, maybe, people in whom coronary artery disease has a higher prevalence. So we do see a lot of that thinking. If the more tests, the more procedures I get, the better the care and the better the physician who's rendering the care.
While we're waiting for Vikas to come back, it seems that he's lost his Wi-Fi. We do have another question for you guys. What are the trends in stable coronary artery disease stenting in European systems where it's mostly not fee-for-service?
Well, actually, most of Western Europe is fee-for-service. I think England, Ireland are different, but interventional cardiologists get paid very well in Italy, in Germany, in Austria. Scandinavia is a little bit more socialized medicine. But even in the United States, if you look at the Veterans Hospital Administration, there's less stent placement in that system where there's absolutely no financial benefit, but still more than is needed, because the people practicing in the veterans system, one, were normally trained in a fee-for-service system, so they've been, as Betty said, marinated in the clogged pipe hypothesis. And the other thing is, even though they are not paid directly in any way from putting in stents, you can believe that the VA hospital administrators monitor the volume of procedures that are done in their cath lab. And if that volume drops precipitously, they don't want that either, because that means that the central VA is going to give them less resources, even though they may be doing a great job at treating patients medically without invasive procedures. So there's all kinds of mixed incentives for doing more, even in the non-fee-for-service environments.
Great. Listen, I just had my internet drop, so I don't know if everybody noticed it or not, but let's keep going here. I want to take a look at the results of our overuse index. But before we do, I want to let our audience know about our next event, which is the 2023 or maybe 2024 Shkreli Awards. The Shkreli Awards is our annual list of the worst examples of profiteering and dysfunction in healthcare, named, of course, after the infamous pharma bro himself, Martin Shkreli. You can subscribe to our newsletter to get notified about all of our upcoming events, including that one. So let's get into some of the results. How prevalent is stent overuse at U.S. hospitals, and what are the harms? So let's take a look at some of the results from the Lown Index. We looked at PCI, stent procedures, or balloon angioplasties, but these days it's mostly stent, at 1,773 hospitals, and we used Medicare claims data over 3 years. So stents were defined as overused when they were placed in patients who had heart disease present for at least 6 months and had been stable. We excluded anybody who had unstable angina, a heart attack, or recent ER visits. We found that hospitals in total did nearly 230,000 unnecessary stents over those years. That's a rate of about 1 every 7 minutes in the United States. Our estimate, very conservative estimate, is that Medicare spent about $2.4 billion on stent overuse, and that's not counting any of the downstream costs like follow-up visits, complications, or the like, as well as the routine testing that would be part of that. About 20% of all stent procedures that hospital performed met our criteria for overuse. What's interesting is, though normal in many ways, there was a lot of variation in overuse rates among hospitals. So when we compared individual hospitals, we restricted our analysis just to the top half, those that are doing above average volume, just so that results would be stable and meaningful in terms of total volume. We have the full results on our website. But here what you're seeing is, of that top half, the hospitals with the highest rates of stent overuse were up to 50% or more. And that means every other stent met our criteria for overuse. And then on the other hand, there were hospitals that barely did any unnecessary stents in 3 years. And that's despite having a high volume of stents overall. So these are the kind of outlier hospitals to illustrate the extremes of what it's like. But you can see the full lists at lownhospitalsindex.org, and you can see that right now. There's even high variation in the same state. So for example, Mount Sinai in Manhattan has had the highest rate of overuse amongst hospitals in New York State, with about 40% meeting our criteria. Strong Memorial in the same state had overuse rate of about 5%. And again, you can see similar comparisons for all the states at our website. So, what do these results mean for patients? What does it mean for policymakers? So let's get into some of this. Let's get into some of the harms of overuse, whether they're physical or financial harms. First question to all of you, and we'll just go around the table. In my mind, given it's 15 years, 16 years after Courage, after Revived, after Orbita, these are pretty big numbers. Do they shock you? Is the variation we're reporting shocking to you? Tom, why don't we start with you? Because you live in this world. You have a view across hospitals, and in your role for care management, you have to think about this a lot. What do you think?
Not shocked by the numbers. As you say, I live in the world of pre-authorization, and I am engaged in conversations on a daily basis wherein physicians are trying to make a case to stent a patient who either has not been managed medically at all or has had minimal medical management for a short duration of time. So, the fact that payers are willing to spend money on a vendor to manage this tells you that the spend is significant. So I'm not surprised.
Yeah. Well, that begs kind of the question I, as a practitioner, hated prior authorization.
Same.
It's a real burden on one's professional autonomy. So, but this is a case where you have to square the circle somehow, and I'm not sure how we do it. David, what about you? Is this surprising to you, shocking to you?
It's only shocking to me on the low end. I'm amazed that there are people that using your metric or hospitals using your metric that you only found single-digit overuse. I would have guessed the average was close to your high end, would be 40 to 50% of stents are done in patients that I would manage medically.
Yeah, it's interesting. We looked, so at Lown, before I came back, Tom Grayboys led a study looking at second opinion patients. We had a series of about 200, and 85% of those we managed medically, even though they'd been told they needed, revascularization. So,
and even that was in the era before we had good medical management, and still they did very well.
Yeah, and still they did well. And then I did a repeat. Unfortunately, we never published it, but I did a repeat where the numbers were not much better. So I think you're right. Betty, what are your thoughts on this?
Well, it saddens me, but it doesn't surprise me, to be honest. And when I think about pre-authorization, it always seems to me as sort of a logical consequence of our unbridled overuse of services, right? If we're unbridled overusing, if somebody's going to watch it. So I'm very much saddened by it. And I do know from other studies that even clinicians who are prepared in a very value conscious way, when they move to a new setting, they adopt behavior of that setting. So I would just give a shout out to my nurse colleagues in the country. There's 5.2 million nurses, 4.2 that are practicing, to really get on the bandwagon and really look at the evidence and be that trusted individual. But it's very, very hard in the hierarchical system in many ways. But I'm saddened. I'm saddened, but not surprised.
Yeah. So what about physical harms, David? What are some of the risks of doing unnecessary stents? You did say, it's relatively safe, but have you seen it harm patients?
Oh, I see that on a regular basis. I mean, there are acute procedural harms that involve perforation of the artery in the heart that you're attempting to stent. There are acute procedural complications of the artery caused by damage to the artery in the groin, where you're accessing the vascular system, and people have bled to death from that kind of complication. Then there's the long-term harm where patients have to be on blood thinners for 6 months to a year after a stent to keep the stent from clotting off, and that can precipitate bleeding in other areas that can be life-threatening. The stent itself can clot off unpredictably in 1 to 2% of patients, and that can lead to a heart attack or death. So there's all sorts of procedural harms that both acute and in follow-up that I see on a weekly basis.
Yeah, that's pretty sobering. I think we've all seen something, not always as dramatic and spectacular as some, but definitely a steady stream. Betty, I know it's probably an interest of yours and something I've thought about, people talk about, though I'm not sure we've connected all the dots. And that's the relationship of high volume practice, especially unnecessary care, low value care, and burnout. Is there a relationship? Does overtreatment contribute to this in terms of extra time, extra effort? What do you think?
Well, first of all, there is enormous amount of moral distress in the healthcare workspace right now. Nurses are twice as likely to commit suicide as the general population. And I think when I talk to my students, for example, the graduate students who are coming back to become nurse practitioners, and I raise this issue of overtreatment, unnecessary care, the stories just pour out of them. Their anxiety, the stress, a lot of times they're leaving bedside nursing, and this is a piece of it because they see all these things that are done and they see things that they don't perceive as being necessary that harm the people that get the service. And so accident or errors happen, but how much more tragic when it's something that wasn't needed in the first place. So sort of the helplessness and the moral distress is very, very real. I mean, there's many things that contribute to it, but the sense of overtreatment certainly is one of them. And it's challenging. I work with undergraduate students as well and ask them to think about the care they saw, what they did, and what was low value and what's high value. And one of the young students just this week said to me, how would I know? I'm 19 years old and I'm just trying to learn how to put my gloves out without contaminating them. How would I know? And they're also brought oftentimes to the field because of the glamour of the cure, the glamour of the cure. So there is so much work to be done to really change our psyche to one of where we really value watchful waiting. But I don't think we can do that without payment reform. We're just throwing fuel on the fire.
Yeah. Well, and the issue of moral distress is a hard one for this particular issue, I think, because as others have said, what in cardiology somebody called the oculostenotic reflex, you see the blockage, you want to open it. It's also true for patients, as David said, you show them the blockage, everybody naturally says, oh yeah, can you fix that? Can you open it? So it's really hard to talk about futility or moral distress when in the moment you think you're being heroic, you're actually doing a great thing. A bit different in that sense from end of life care. So big challenge for all of us. A lot more we could say, but just quickly on the cost side. Tom, I don't know what your various relationships are with different provider networks and groups. I presume many of them are moving towards global budgeting or some form of financial risk. Certainly there's been talk about this for 20 years and maybe we're finally starting to get there. But, $2.5 billion is our conservative estimate of what these stents are costing Medicare in the country. My guess is it's probably higher. Can you imagine what we could do with that kind of money? Where else might it be better spent, just from your perspective?
Yes, I was going to tag on to David's answer. He spoke about the harms of unnecessary stenting, and he spoke about the harms to the index patient. But you could also speak to the harms to the other patients by virtue of using healthcare dollars on low-value services and thereby depriving other patients of services that are of higher value, maybe improving access to care for those who have difficulty accessing care, maybe more focus on prevention and lifestyle choices rather than cure, I mean, there's so much that could be done with that amount of money, that I think it behooves us to wake up and admit that we're in a resource constrained system, and think more globally, think outside of the patient sitting in front of you and what dollars you can spend on that individual, and think more about the whole.
Yeah. Well, let's talk a little bit more about what we could do. You know, what kind of solutions might we think about or recommend? But let's start with a question from the audience, because I think this is maybe the biggest challenge. And the question is, help me explain to my 80-year-old mother why, quote, unclogging the pipes, unquote, doesn't have the effect we think it would have. Because she would probably just say, well, that doesn't make any sense. So though we have data on the outcomes, is there a plausible story? Every time there's a paradigm shift, the shift in the paradigm is not just the data, it's also the narrative. So is there a new narrative? Is it emerging? What is that narrative? David, I'll toss it to you first.
I mean, I see a lot of these patients that do come for second opinions, and what I tell them is that 90% narrowing they have looks dramatic on their angiogram, but its real importance is that it's a marker for the dozens and dozens of 10%, 20%, 30% blockages that aren't going to be stented. And it's those blockages that actually rupture, cause heart attacks, and kill you. So fixing the 90% blockage is cosmetic surgery. Preventing the 10, 20, 30, and 40% blockages that nobody would ever stent from causing a fatal heart attack is done by medical therapy. So in terms of optimizing outcomes, we can skip the stent, we can skip the cosmetic part of the procedure, and just go to the disease modification part of the treatment, which is medical therapy and lifestyle improvement.
Yeah. Here. I mean, certainly the notion that this is a systemic disease of all the arteries, it's not a blockage, I think is central to a new narrative. And of course, there's a lot more there. So back to you, Betty, question. We need a movement for high value care. You've stated it pretty eloquently yourself. So how can nurses be a part of that movement? You know, what has to change for them to be able to take a leading role?
That's a great question. And I would just comment, thank you for the opportunity to be here, because I think it's been, I think nurses have not grabbed hold of this as much as we absolutely must. We have new accreditation criteria for baccalaureate and higher degree programs that include an emphasis on cost, waste, and unnecessary care. But it is actually really hard to change the culture outside of what they see. So what I'm really hoping that through conversations like these and others, nurses really grab hold of this as an ethical obligation. It has economic parameters, but it is an ethical obligation. And nurses are consistently viewed as the most trusted professional. More recently, there was a survey that was looking at who do you trust to change the healthcare system, and nurses had the greatest proportion, roughly double that of physicians. And physicians and nurses and others just have to work together to really recognize the public good. I feel that as a nurse and as a woman, there's some things that I can question more easily than other people might be able to, right? Like I can question mammograms in a way that maybe a male physician or a business owner wouldn't be able to. So I think nurses see the harm, and they have a lot of moral distress around overtreatment. But the what is more like, what do we do about it? And that's what some colleagues and I are actually looking at. She's an end-of-life palliative care person. I'm in the payment world. What prevents nurses from actually working to redesign this? You know, if physicians are the pilots, nurses are the air traffic controllers. So how do they take that authority and responsibility to really broaden our contract with society to include getting rid of unnecessary care, which causes harm, financial, emotional, et cetera?
Yep. Boy, there's so much. We could devote a whole hour on just this issue, and maybe someday we will. There's a lot more to be said, clearly. Tom, you know I was going to ask you this question, but you have some experience on the payer side. Why can't Medicare and Anthem just stop paying for this?
It's probably a question that David would have asked me. Why not just say no? So I think there are several reasons. Your data, Vikas, is based on Medicare members, beneficiaries. And I think one of the problems is that Medicare coverage criteria lag far behind the evidence. And so if you go now and look at LCDs, local coverage determinations for various parts of the country, you will find shocking coverage criteria for both coronary angiography and PCI, very different from the latest evidence. And so as long as those coverage criteria are there, it's very hard to tell a physician who wants to do a procedure that we're not going to pay for that. And those coverage criteria, the Medicare coverage criteria, apply to fee-for-service Medicare. They also apply to Medicare Advantage. And in some respects, they dictate what the commercial payers, the stance that they will take in terms of coverage. So that's one issue. The second issue is that if the use of PCI in stable coronary disease was an absolute no, never in any circumstance, then it would be easier to control. But there are circumstances where you should offer PCI to a patient with stable coronary disease. So for example, the patient who has persistent unacceptable angina, having taken optimal medical therapy, that's a role for PCI still, according to guidelines and evidence. And so, if there's a loophole, then a physician who wants to use that loophole will. And so, we have to listen to those stories of, yes, I tried optimal medical therapy and the patient still has persistent symptoms, and we have to take them at face value and approve it if that's the story. Other reasons are legislators might be very vocal about restricting access to care. We have that clogged pipe hypothesis, which is out there. And so a legislator might latch onto that and say, this payer is restricting access to care that we feel is appropriate, even though clinicians know that it's not. And then, of course, there's the noise from the patients, right? The patients may be very bothered after they've seen their coronary angiogram and been told that they are going to be set up to have a stent put in next week, and then get a call to say, hey, your insurance won't pay for that. So there's a lot of stakeholders in this, and it's not as simple as just saying no.
Yep. Well, I know when I was practicing, and certainly, what I learned from Dr. Lown was you can manage coronary disease much of the time, maybe not all, but much of the time without the angiogram. I know that was actually a great debate whether that was malpractice or not. But in fact, I think you can, and that actually addresses some of these issues of the oculostenotic reflex. Well, even there's a ton more we could be talking about. We need another hour for that, but we don't have a whole lot of time, so we want to get to some audience questions. But David, one last thing, you've talked about your practice, with second opinions and what you say, how you might approach this with the patient. Do you ever worry that you're going to get a bad outcome and that's going to come back to haunt you? Or maybe a different way of saying that is, how do you deal with your colleagues who don't see it the way you see it?
Well, to answer your first question, I know I'm going to get a bad outcome. The question is whether I could have done something to prevent that outcome. And, based on the best available evidence, I'm going to get the best outcomes for my patient that we know how to get. In terms of my colleagues, I don't dictate other people's practice. I try to set an example, and I try to show my example to our residents and fellows, the trainees, with the hope that some of that wears off. And then when they go out into practice, they'll at least consider my approach. But, I'm definitely in the minority. Let's just say that.
Okay, well, we got a lot of audience questions and we are rapidly running out of time. So I don't know if I can call this a lightning round, but here we go. So is it possible that some patients in our study, I think they mean the Lowndes study, did not have a diagnosis of unstable angina in the prior 2 weeks or didn't have an ER visit, but nevertheless had unstable symptoms earlier than the 2-week window? And could that be what's influencing the patient's decision to stent? I'm going to answer that. I mean, I'm happy to hear others' opinions, but my view is if somebody has been stable enough over that period of time, then it's definitely worth revisiting that decision. If the decision was made 3 weeks ago and nothing has happened, or it's not crescendo, or the pattern's not unstable in that sense, it is definitely worth a revisit. My own practice would really be in that setting. And this happens a lot. Somebody comes with new onset angina. Is that unstable or not? You don't know, but it's new onset. So by definition, it's unstable. But if you manage it medically and you see that patient a month ago, the thing to do is to keep following carefully and closely week after week. It takes intensive management, but it can be done. And there's probably more to say, but David, Tom, anything you want to add to that?
Nope, I think you covered it.
Yeah. Can someone describe what might be typical in terms of medical management for stable coronary disease? I realize it could differ substantially depending on the underlying risk factors, but can you give examples of some medication management regimes? I think some of this was answered in the chat, but maybe we'll take a few minutes. What constitutes a comprehensive, effective medical management program?
Well, I mean, the term OMT, or optimal medical management, was first coined by Dr. Bowden from Boston in the Courage study, but that term is not just a term of medication use. It's a term of lifestyle modification, risk factor modification, as well as medical therapy. But just to get to the medical aspect of it, the way I look at it is there are two types of medications. One is disease modifying, that is to prevent progression of the disease and prevent adverse outcomes, as statins would be in that group. And then there are symptomatic treatments for angina. And in that group would be versions of nitroglycerin that can be given in pill form or spray form or under the tongue. Calcium channel blockers are occasionally useful. Beta blockers are occasionally useful. There's a newer drug called ranolazine that's occasionally useful. But every patient is different. Every patient has different tolerance for the different medications. For example, patients with asthma don't usually do well on beta blockers. So it's an individualized, tailored approach in terms of medication, but always coupled with lifestyle modification and risk factor control.
Got it. Here's a question. Could the differences in overuse rates that we're reporting merely be a reflection of differences in coding practices? Is it possible certain institutions are less likely to code unstable angina or the other exclusions that Lowndes used? Thoughts on that one, Tom?
So there was some literature around upcoding, taking patients who had stable angina and upcoding them to unstable angina in order to make the PCI appropriate. And I think that does happen, maybe less so than it did, but I think it certainly happens. Other than that, I can't think of a method by which the coding could make something that is appropriate seem inappropriate, or vice versa.
Yeah, I
Yes.
mean, that would be my comment, which is that we have an army of coders. We have a whole cottage industry to be sure. Everybody's squeezing every last dollar out of every case. And so if there's a bias, it's to be sure everything's captured. I'd be hard pressed to believe things are being left on the table. That's effectively money being left on the table, which in American medicine is a sin from a business point of view. So yeah, I mean, it's theoretically it's possible. It's certainly something I'd be open to if somebody had some data to support it. Another question, are there any, and I guess this is also for you, Tom, are there any alternative payment mechanisms that have actually succeeded in reducing unnecessary coronary stenting?
Yeah, it's difficult to get specialists to sign up for alternate payment models if they're happy with the status quo, right? What's in it for them? So most of the alternate payment models have been with primary care physicians, but there are some limited number of examples of physicians who become part of a healthcare system, and you can look at their utilization pre and post. And this applies not just to PCI, but to services rendered in general. And you see, a change in their utilization. But even in those salaried models, there's often some incentive to maintain volume, some bonus structure or something. So it is difficult really to pull cardiologists into these kind of models that are truly neutral.
Mm-hmm.
Very briefly, if I could just briefly add to that, there is some evidence that risk-bearing ACOs do make efforts to reduce low value care writ large, not specifically focused on this. But I so agree with Tom. If it's built on an underlying fee-for-service chassis, it's still in the water.
Yeah, I've thought about this for a long time. I think there are solutions, but they would require major restructuring and re-engineering of care delivery, and I'd need a second career to make that happen. Last question, and we are running out of time. This is really for all of you. Have the professional societies, American College of Cardiology, American Heart Association, nursing societies, what position have they taken, and have they taken what would really be an informed opinion and offered appropriate public guidance? David?
Unfortunately not. I mean, the American College of Cardiology, American Heart Association just published new chest pain guidelines last year or the year before, and it's filled with recommendations of procedural overuse, including both stress testing, coronary CT scans, as well as invasive coronary angiography. So the whole thing was modeled on the clogged pipe paradigm of coronary disease, and that was only 2 years ago. So to say the least, they've been missing in action.
Tom?
Yeah, I agree. I think that they serve several different masters, and so they have to keep that in mind.
Yep. Betty?
Well, I just comment, the organizations are there to support the members of their organization. And that's where the rub is. American Nurses Association Foundation did fund the Reimagining Nursing piece, but it's relatively small, not directed towards this. So there's a lot of work to do and a lot of opportunity, I think. Or responsibility, I should say. Yeah.
Thank you. Thank you all. So before we go, and we have to go now, we'd like to give a huge thank you to our guests. Betty Ramber is Professor of Nursing and Interim Dean at the University of Rhode Island. Tom Power is Senior Medical Director of Cardiology at Carillon Medical Benefits. David Brown is Clinical Professor of Medicine at Keck School at the University of Southern California. Thank you all for joining us.
Thank you.
Thank you.
Thank you.